CMICA TV. CMICA TV.
Hola, ¿qué tal? Buenas tardes. Estamos aquí en CMICA TV y estamos de nuevo con muchísimo gusto de presentar a uno de nuestros ponentes internacionales, es Dave Stukus, y él viene ahorita en esta breve grabación para platicarnos sobre anafilaxia. Welcome, Dr. Dave. So, how could we define anaphylaxis from the clinical and really practical point of view?
So that's a great question, and there's often a lot of confusion in regards to the diagnosis of anaphylaxis. First and foremost, it is a clinical diagnosis. We cannot rely on any laboratory tests or anything else like that to diagnose anaphylaxis. The overall concept is that it's a rapidly progressive, systemic reaction, typically caused by an allergic reaction, that causes manifestations in at least 2 or more organ systems. Now, every organ system can count. The skin is often involved, but not always, and typical symptoms would include itching, rash, hives, or swelling. You can also have symptoms of the respiratory tract causing wheezing, difficulty breathing, cough. Gastrointestinal symptoms can include vomiting, nausea, cramping, sometimes diarrhea. You can have swelling of the tongue. Sometimes you can even have cramping of the uterus. And then you can also have vasodilation, and people would pass out. Anaphylaxis typically is going to be very rapid in onset and progress rather quickly over a matter of minutes to 1 or 2 hours. So it's not going to be a very delayed onset, sort of smoldering manifestation of any of these symptoms.
Thank you very much. So, which are the patients at risk of developing anaphylaxis? Who could we expect, or which triggers, mainly in children, could be the triggers for anaphylaxis?
So the easiest patient to identify at risk for future anaphylaxis is somebody who's already had anaphylaxis. So of course, if they present clinically with anaphylaxis in the past, they should absolutely be evaluated for any potential allergic trigger, including foods, medications, or venom. Aside from that, not everybody has to have prior anaphylaxis to experience future anaphylaxis, and oftentimes in regards to food allergy, they can have mild symptoms to begin with and then have anaphylactic reactions with subsequent ingestion, particularly if they eat larger quantities or it just may be more severe in the future. So any child who has a known food allergy, particularly allergies to peanut, tree nut, seafood, but can also include milk, egg, wheat, or soy, they should be prepared to recognize and treat anaphylaxis and have their own epinephrine with them at all times in case they should have accidental ingestion causing future episodes. Aside from that, medication allergies are rather infrequent in children especially, but they can occur. So for a child who has suspected or known anaphylaxis or reactions to medication, they should be educated and be prepared as well. And then we really worry about venom, because venom reactions can occur suddenly. Oftentimes people can be unprepared. Now for children, or really for anybody, we don't need to worry about the general population being at risk for anaphylaxis from venom, although it does occur, but only for patients who had prior reactions considering anaphylaxis. To reduce their future risk as well.
Thank you. So the diagnosis is absolutely based on signs or symptoms. Now, can we talk about the first-line treatment, please?
The only effective treatment for anaphylaxis, and I say this, I'll repeat again, the only effective treatment is epinephrine, also known as adrenaline. Epinephrine should always be administered intramuscularly in the lateral aspect of the thigh, where it can be absorbed very quickly into the large blood vessels and circulated immediately. Epinephrine is the treatment of choice for anaphylaxis for several reasons. 1, it works very quickly. 2, it can treat every single symptom associated with anaphylaxis, from skin symptoms to respiratory compromise to hypotension. And 3, epinephrine can actually close up the mast cells and basophils that are being unlocked and releasing mediators causing the reaction in the first place. So we always want to use epinephrine as the first-line treatment for anaphylaxis. Antihistamines have a longer onset of action, typically up to 30 or even 60 minutes, so they may not work fast enough. And antihistamines often will not treat all of the symptoms associated with the anaphylaxis, so we never want to use that in place of epinephrine. And then lastly, Steroids are frequently used in the treatment of anaphylaxis, but they absolutely have no role whatsoever in the acute management of anaphylaxis. And there's a very simple reason why. The mechanism of action. For steroids to work, they have to bind to a receptor on the nucleus, a receptor on the cell surface of the cells, and then get transported to the nucleus, where they work to stop the transcription of inflammatory mediators. It doesn't reverse any symptoms acutely. It takes 4 to 6 hours before we even see any benefit whatsoever. So steroids, 1, won't treat the symptoms, and 2, take way too long to offer any benefit in the acute setting of anaphylaxis.
Thank you. So there was this idea about when in doubt, administer epinephrine, but now we must say doubt no more, because the diagnosis of anaphylaxis and the main treatment should be clear for everyone who handles people who can potentially develop a big allergic reaction. So could we talk about where is the place where most of the anaphylaxis take place? Because unfortunately, it's not at the medical settings, right? So how could we advise the primary care physicians and the specialists and even the families to be prepared?
So you're absolutely correct. Most episodes of anaphylaxis, other than those induced by drugs or in the perioperative setting, do not occur in the hospital setting. So for our patients who have a prior history of anaphylaxis or who are deemed at risk of having anaphylaxis in the future, they should be educated, 1, what are they allergic to? So that requires identification and proper testing. 2, avoidance measures. So in regards to food allergy, people should be educated to discuss their food allergen with food handlers at restaurants, bakeries, ice cream stores, also to read labels on all packaged products to make sure they don't accidentally ingest their food allergen. And then they should always have their epinephrine with them at all times in case accidental ingestion does occur, which does happen, unfortunately. This has been documented to occur in the school setting by accidentally eating what they're allergic to. It can happen at home. It can happen when they're visiting relatives or when traveling abroad. So patients and families need to be well aware of these potential accidental ingestions that can occur and be prepared to treat it. Now, when it comes to venom, of course, most of those are going to occur at the site where stings occur. So, rarely is that going to happen near a hospital facility or in the medical setting. So people with venom allergy or who have had prior anaphylaxis should be educated to walk away from any identified hive or nest. They shouldn't be the one to go out and try to get rid of that from the backyard or out in the country. 2, ideally they won't walk around outdoors in bare feet because they may accidentally step on something such as a honeybee that could then sting them in self-defense. But then we need to educate our families and patients about their risk factors and how to manage anaphylaxis. And then lastly, number 3, is to be prepared. So make sure that patients at risk for anaphylaxis understand what are the signs and symptoms I need to watch out for, and then what treatment should I administer should symptoms occur. So I can't say it enough. Epinephrine is the first-line therapy for anaphylaxis. Anybody deemed at risk for having anaphylaxis should absolutely have their own epinephrine with them at all times and be educated on how to use it.
Thank you very, very much once again. Muchas gracias. Hasta luego.
CMICA TV.